Dear Chairperson, colleagues, ladies and gentlemen, first of all, I would like to thank the organizer for inviting me to this Apostle Oncology 2021 meeting. And my task today is to present the development of hepatocellular carcinoma in treated HPV patients. I'm Dr. Jia-Horng Kao from Taiwan. This is my disclosure. My presentation will include the overview of hepatocellular carcinoma, the HPV-related acc in treated HPV patients, and lastly, how to prevent HPV-related acc. As you know, hepatocellular carcinoma is the 7th most common cancer worldwide, with estimated incidence of 0.5 to 1 million new patients per year. It is also the second leading cause of cancer-related deaths, and about 600,000 deaths globally per year. The ACC has strikingly different geographic distributions, which is highly prevalent in our region. And there is an increasing incidence of ACC in many countries. In this figure, the global mortality of primary liver cancer in 2018. You can see the ACC-related mortality remains high in some Asia-Pacific countries, such as Mongolia, China, Korea, and Southeast Asian countries. These figures show the trends in ACC incidence rate by country. In the upper panel, we can see the decreasing incidence of ACC in East Asia, Southeast Asia. However, in the lower panel, we can see the increasing incidence of ACC in Southern Europe, Western Europe, North America, South America, and Oceania, which deserve further attention. Regarding the etiologies of liver cancer, we all know that the liver cirrhosis and the chronic viral hepatitis are the major etiologies. However, the clinical significance of non-alcoholic steatohepatitis in liver cancer has been increasingly recognized. This figure shows the global incidence of primary liver cancer in 2018, and the liver cancer accounts for 80 to 90% of the primary liver cancer in our region, and in East Asia, except in Japan, the chronic hepatitis B is the leading cause of HCC. Let's move on to the HPV-related ACC in treated HPV patients. Chronic hepatitis B affects more than 250 million people worldwide, and cause more than 800,000 deaths, including liver cirrhosis and ACC per year. And the currently approved antiviral treatments, including the NUC and the pegylated interferon, which are highly effective in suppressing viral replication. The NUCs can reduce the risk of mortality due to liver disease by 50 to 70%. But the viremia may occur following a treatment cessation up to 50 to 90%. And fewer than 5 to 15% of those treated can achieve the loss of circulating hepatitis B surface antigen, also called a functional cure. In 2016, the WHO called for the elimination of hepatitis B as a major public health threat by 2030. This flow shows the disease progression in Asian chronic hepatitis B patients. The infants born to HPV carrier mothers have a higher risk of becoming chronic hepatitis B. And fortunately, about 2/3 of chronic HPV carriers will become inactive state with disease remission and a decline of HPV DNA level. And 1 to 2% of them may enjoy the loss of surface antigen, which confers a favorable prognosis. In contrast, 1/3 of them may have chronic hepatitis. They may progress to liver cirrhosis and SCC with various incidents. So these patients have adverse outcomes and need antiviral therapy urgently. We know that the HPV DNA is the driving force of disease progression and SCC development in chronic hepatitis B patients. So from the earlier REVEAL HPV study and our own Eradicate B cohort, we know that the higher the baseline HPV DNA level, the higher the risk of SCC development over time. However, even in patients with low HPV DNA, that is less than 2,000 international units per ml, if these patients have a high quantitative surface antigen level, that is more than 1,000, they have a 5-fold increased SCC risk compared to those with low hepatitis B surface antigen. Therefore, the ideal goals of HPV therapy is to cure both virus and liver fibrosis progression, as shown in this cartoon. Although many patients receive nuke therapy, there are still unmet needs. For example, there is no direct effect of nuke on CCC DNA, and there is a high relapse rate after nuke discontinuations. And even a patient receives the long-term antiviral therapy, the risk of SCC remains. So the next question is, what are the factors to predict the risk of SCC in nuke-treated patients? In this nationwide cohort study from Taiwan, the Dr. Wu reported compared to untreated chronic hepatitis B patients, nuke-treated patients have a lower cumulative incidence of SCC. That is 23% versus 7.3%. And the further analysis show that no treatment, old age, male gender, and the liver cirrhosis are the risk factors for SCC development. In addition, the concomitant use of statin, NSAID, or aspirin seem to have a protective effect. However, these findings need to be validated by further prospective studies. In Taiwan, we can see the reduction in SCC mortality through the National Viral Hepatitis Therapy Program since 2003. In this figure, the reduced rate of SCC mortality in all age cohorts by 5 to 8 years after the introduction of a National Hepatitis Therapy Program. In our C-team study, we found that compared to historical untreated chronic hepatitis B patients, the entecavir-treated HPV-related cirrhosis patients have a lower cumulative incidence of SCC with a hazard ratio of 0.4, suggesting a 60% reduction of SCC in entecavir-treated cirrhotic patients. However, our further analysis showed there is a right shift of lifetime cumulative incidence of SCC in entecavir-treated patients compared to historical untreated controls, suggesting that SCC may not be prevented but delayed. Therefore, we need to continue the intensive SCC surveillance program in elderly patients. In our recent study, we can see the long-term effectiveness of population-wide interventions for hepatocellular carcinoma in Taiwan. I would like to draw your attention to the National Hepatitis Therapy Program since 2003. So there is the antiviral therapy, was associated with a 15% decline in SCC incidence in a middle age group. So how about the baseline risk factors of SCC development in treated chronic hepatitis B patients? In a recent review, the old age, the hepatic dysfunction such as low albumin and high bilirubin level, presence of diabetes, the liver fibrosis severity, male gender, and the neoplastic or regenerative markers such as alpha-fetoprotein can serve as the baseline risk factors. On the basis of these risk factors, many SCC risk models have been developed for treated chronic hepatitis B patients. However, many of these risk models are not externally validated. Are there any on-treatment predictors? So in a study from Korea, this is a 2-year landmark analysis of a South Korea historical cohort study. We can see the earlier ALT normalization during a nuke treatment is associated with decreasing risk of SCC. And this association is independent of fatty liver at baseline and the virological response during nuke therapy. In a study from China, they found that the alpha-fetoprotein and the gamma-GT level at month 6 of nuke therapy can predict liver-related events in patients with compensated Hpv-related cirrhosis who receive antiviral treatment. In a study from Hong Kong, the viral suppression can decrease the incidence of SCC, but a patient who lost surface antigen had the least risk. So in this figure, the patients with no complete viral suppression, the 8-year cumulative incidence of SCC is 8%. And for patients with complete viral suppression, 5.6%. And for those who can experience HBsAg loss, the incidence is only 0.6%. In a study from Japan, the authors look at the impact of hepatitis B core-related antigen at 1 year of nuke therapy on risk of SCC. So you can see if the hepatitis B core-related antigens is 1.9 log unit per ml at 1 year nuke therapy, the risk of SCC is still high. That's for E-positive patients. And for E-negative patients, the cutoff is 4.4. In Taiwan, our own study showed that the baseline M2-PPGI, which is a fibrosis marker of 1.7, can predict the risk of SCC in treated HPV patients. Our another study further confirmed that the higher M2-PPGI level at virological remission can predict the risk of SCC and mortality in treated patients as shown in the lower panel. So how to prevent HPV-related SCC? I think there are 3 tiers. The primary prevention is to target the total populations by universal HPV vaccination and antiviral prophylaxis for highly virulent mothers and interrupt the possible transmission route. And the secondary prevention is to treat the HPV patients by antiviral therapy and also continue SCC surveillance. And the tertiary prevention is to target the patient with SCC after curative treatment by using antiviral therapy to improve liver reserve and also reduce the SCC recurrence. Dear chairpersons, colleagues, ladies and gentlemen, the strategies to eliminate HPV by 2030 is the integration of primary health care institute and the public health system through the prevention of individuals from acute hepatitis B virus infection and the treatment of patients with chronic hepatitis B. Before the end of my presentation, I would like to welcome all of you to attend the 2022 APASO Single Topic Conference on hepatocellular carcinoma in June in Taipei. With this, thank you for your attention.